Our presenter today will be Samantha Olds-Fry. She is the CEO of the Illinois Association of Medicaid Health Plans, also known as IMHIP. Samantha has a decade of experience in healthcare and appropriations policy, and as Executive Director and Chief Executive Officer at IMHIP, she is responsible for coordinating legislative strategies, testifying before legislative committees, and working closely with state agency administrators to formulate and implement policy that positively impacts members. Without further ado, Samantha, I will turn the presentation over to you.
Thank you, and good afternoon, everybody. Thank you for joining us today. We are going to dive into this presentation, into this topic. While I am presenting, I do want to make sure everybody knows that this was built in conjunction with all of our Medicaid health plans that are serving the Health Choice program and with the state as well. For those of you not familiar, these health plans, Blue Cross County Care, Illini Care, Meridian, Molina, and Next Level are our health choice plans in Illinois today. We want to talk about, when we talk about children with special needs and special needs children, who are we talking about? And I think given the conversation over the last few weeks, this is even more critical than it's been in the past. It's just making sure we all have a similar understanding of the children and the populations we're talking about when we talk about this transition. So first of all, children with special needs, very separate from two other categories, one of which would be former youth in care and one of which would be current youth in care. We'll talk about those a little bit later. But the population of special needs children or children with complex healthcare needs is separate from those two populations. These are children who are under the age of 21, who are receiving supplemental security income or SSI, are classified as disabled, and children who are receiving care coordination through DSCC, also known as CORE. So children who fall into one of those three buckets make up our special needs children population in Illinois. To give you a sense of what we're talking about with how many children went into managed care on Saturday, we've broken it out both by region and then by category. So this first column here that you see is for children who have the definition of disabled. So about a little over 5,000 statewide. You would expect about half of them are in Cook County and then the rest are throughout the state. Our DSCC children, 2,400, a little over that. Again, a little less than half in Cook County, but the majority in Cook County and then the rest throughout the rest of the state. And then 13,303 children are receiving SSI. Again, the bulk of those children are going to be in Cook County, the rest are throughout the state. And that brings us to a total of 20,825 children are now receiving their care coordinated through the managed care organizations. And that began on Saturday. But to put that in perspective, and something that I think has really been lost in the conversation, brings us to the next slide. Children who have complex healthcare needs or special needs children were always able to opt into Medicaid managed care, and they've been doing that over time already. So back in November, we actually had already 16,434 children already in health plans. They had their families had actively selected a plan, and they're already receiving care from these health plans. So they have a little less than half, but a very large chunk of children. And so what that means is the plans that are operating today are familiar with the needs of these children. They have care coordinators who are accustomed to dealing with children with special needs. They are accustomed to the complex care plans that exist for these children for dealing with the provider type and the specialized providers that have these services that these children need. So this is not going sort of from 0 to 60, but really we already had about 45% of the children already in managed care. And so this is really just sort of completing that transition that took place on Saturday. So who is excluded? So when we talk about special needs children, especially when you see that number, about 36,000 or so, you might be thinking, well, that seems a little bit low. I think it should be a little higher. That is because not all special needs children are going into Medicaid managed care. If you are receiving care through the MSTD waiver, then you are not going into managed care. You will continue to have your services through the fee-for-service program. Additionally, if you're receiving nursing or private duty nursing or personal care services program, you are also not receiving your services through managed care. So those two populations are excluded from the definition and did not transition on Saturday. Separate and apart from children with special needs is another population, and that is our DCFS children. Those are broken into also two categories. So first, the current youth in care. It's really important, and this has really been confused over the past 2 weeks. Current youth in care, if you are currently under the legal custody or guardianship of DCFS, you're not going into managed care until April 1st of 2020. So that did not take place on Saturday. If you were a former youth in care, then that took place on February 1st or Saturday. This would be children and families who achieved unification within a year, youth who have emancipated, families who have achieved permanency either via guardianship or adoption. So those children received care coordination effective on February 1st. It's really important also that we remember that the current youth in care, again, effective April 1st, will be going into a program called Youth Care. Youth Care is a program that is run by the Centene Health Plan. The Centene Health Plan in Illinois today, they're operating under the name Meridian, but Youth Care is a standalone program that will have a separate phone number, special requirements, all of that, specific and unique to the DCFS current youth in care. There are and there have been webinars and education for providers from Youth Care. This is not that. However, I do just want to make sure that you do have that resource available and do know sort of where to look for that information, because it has become quite confusing over the last 2 weeks. Former youth in care are able to select any of the health plans. Their families are able to select any of the 6 health plans. However, if they don't select a health plan, they'll be assigned to youth care. They'll be auto-assigned into youth care unless they actively select a different health plan. What we did see is a lot of families did select their own health plan, and so there will be former youth in care throughout all 6 health plans, but there are also some still within the youth care program. Implementation. So how is this being implemented? So first and foremost, our special needs children, this program went live February 1st. That was after listening to stakeholder concerns and consultation with DCFS, extended conversations. We went live on February 1st or Saturday. DCFS, as we just talked about, I'm going to just reiterate because it's been so confusing. DCFS current youth in care, the health plan called Youth Care, administered by Centene, is going effective 4/1, April 1st. Former youth in care who did not select a different health plan will be auto-assigned to Centene, the Youth Care plan. That went live February 1st or Saturday. Even if you were auto-assigned into youth care as a former youth, you still have 90 days, your family or you have 90 days to switch and to select a different health plan should you like. Special needs children, those populations, those children were enrolled on February 1st. they selected plans that were auto-assigned based off of their PCPs. Were not auto-assigned into just a single plan. They were auto-assigned sort of through the normal algorithm. But even if they selected a plan or were auto-assigned, they still have 90 days to switch health plans. Additionally, all special needs children and former youth in care have a 180-day continuity of care period. What does this mean? It means that health plans have to offer a 180-day transition period for children enrolling. Members may maintain their current course of treatment with providers outside of a health plan's network for 180 days. This includes all provider types, including behavioral health, medical, long-term supports and services. If a provider is out of network, they'll be reimbursed at the Medicaid fee schedule. Providers serving these special needs children are encouraged to contact and contract with Medicaid managed care organizations. If you are a provider serving one of these special needs children and you are covered under the continuity of care period, we still encourage you to contact that health plan just to let them know you're working with that child. Especially, this is always important regardless of the children, but when we're dealing with special needs children, the more communication we can have, the quicker we can get in touch, the better it will be for the children we're collectively serving. This will allow for the health plan and the physician or the provider to begin communication. This will make sure that the health plan has in their system that you're covered under continuity of care. This will make sure they know, who to reach out to if there are questions or there's a dialogue. And so that's so critical to begin that conversation and communication early. What's also really important to remind everybody, especially when we're talking about special needs children, is providers must go through IMPACT and be enrolled prior to pursuing contracts with the health plan. That's so important because some of these children may also have a Medicare benefit, but in order to be paid by a Medicaid health plan, you have to be enrolled in the Medicaid program. And so if for that continuity of care period to apply, or for you to get a contract and be a network with a health plan, you have to be enrolled in the Medicaid program. So it's so important. What's also important is if you are a provider and you register in the Medicaid program and you register through IMPACT, you only have to serve the children, the number of children you want to serve. So if you make a decision, I'm only going to serve the 5 or 10 families I've already been serving, that's absolutely fine. That is your choice. But if you want to be paid and reimbursed for those 5 or 10 families that you're serving today, you have to be registered. And if you contract with a health plan, you as a provider, should you choose, always have the ability to say, I do not want to be listed in a provider directory, or I don't want to accept new patients. That is always within your right as a provider. So there are, just because you're enrolled or just because you're contracted does not mean you have to serve more Medicaid members than you're comfortable with. Because there's so much change going on in the first quarter of 2020, we just want to highlight these items for you as it may be important, especially while you're serving these children. The first is ordering, referring, and prescribing. You can see the notice from the department there. This requires all providers who order, refer, or prescribe services to a Medicaid member, special needs children or not, must be enrolled in IMPACT. The second is the universal formulary. It means that all health plans are required to follow HFS's PDL. They are not allowed they have to follow that with regards to preferred and non-preferred drugs. They're not allowed to have drugs as preferred that are not the state's preferred drugs. You can also find out more information on our website here at that link there below. IMPACT. This is so critical. We do first and foremost, I get questions every time of where is the state on processing IMPACT applications? Last time we spoke with HFS and inquired about this, they told us that they were at 35 days of processing complete and accurate applications. However, again, because of ORP, because of contracting, because of, especially when we're talking about these special needs children, we just want to reiterate, you must be registered in IMPACT in order to serve these children. You must be billing and prescribing and ordering and referring with taxonomy numbers and NPIs that are registered in IMPACT. You must register all applicable provider types and specialties. And if you are you have several provider types, you need to actually register separately with separate and unique NPIs. And this is really critical in serving these children with special needs because, again, historically, there were a lot of providers that were being reimbursed by the Medicare side and were not going to be reimbursed by Medicaid, so they were not registered in IMPACT to serve these children. However, if you're going to prescribe anything for these children, if you are going to order or refer anything for these children, you need to be registered so that these families don't have disruption in their health care. So we're going to dive a little bit into Medicaid managed care information and what's important for you guys to know about health plans, how we function, and how we're here to serve the families, but also how we're here to assist you as providers. So first and foremost, some of you may already know all of this, but we think it's important to just level set. What are the Medicaid MCO characteristics? Because they are different than some of our commercial partners. First and foremost, we have to have services at least equal to fee-for-service Medicaid. We're always allowed to offer more, but we're never allowed to offer less. We have network capacity standards. These are reviewed by an external entity, auditing entity that's contracted with HFS. We have to provide updated files to them regularly. We have mandated provider trainings and policies. We have robust fraud, waste, and abuse standards. And our care coordination standards have defined staffing ratios, contact standards, education and experience standards as well. So again, we have experience serving this population. We were already before February 1st serving over 16,000 children statewide. Those care coordinators have defined staffing ratios, again, regularly monitored by an outside entity. And they have to have specific experience. They have to follow certain guidelines. We follow a person-centered model of care, all highly regulated, and a lot of oversight. The goal of all of our care coordinators is to better integrate behavioral health services and physical health services for these children to ensure that they're getting those regular clinical health care needs such as vaccines and regular checkups, along with their more complex needs based off of their situation. So the real purpose of care coordination is to support families and ease the navigation of healthcare to ensure a seamless process. All children defined as special needs children will receive care coordination either by the MCO or by delegated or contracted community-based organizations such as DSCC. However, in the event of an issue with a contracted entity, if there is any confusion, you are always allowed and encouraged to call the assigned MCO. Care coordinators are required to have training and experience serving this population. Again, it's not just that we say they have that experience or that training. An outside entity reviews that and verifies that. Same with the ratios. They review the care plans. They review engagement. All of that is reviewed and monitored regularly by HFS and their external review organization, which, if you were wondering, is HSAG in the state of Illinois. The responsibilities of care coordinators. What do these care coordinators do? What are they supposed to be doing? First and foremost, their number one goal, they are speaking with the family to discuss primary concerns and goals that should be addressed. They send out invitations for meetings. They secure conference calls, in-person meeting locations. They use clinical skills to facilitate an evidence-based conversation of goals. Again, a lot of our care coordinators especially for these populations. These are licensed clinical social workers. These are highly skilled, highly capable folks. They're making sure that the members and families' concerns are met and that the family understands the information presented. It's not enough to present a really well-written, documented care plan if the family doesn't understand it. It's not enough to have an action plan if the family's not on board. So they also summarize the meeting, confirm the responsible parties for any action items, walk through any follow-up, then they document and record that so it can be audited by that outside entity. We escalate any potential risks as needed to leadership and appropriate entities. And then above all, we advocate for the family and support the family to advocate for themselves. So we want to walk through sort of what a care coordination model looks like. What does this mean? And why does this differ? And how does this differ from what some of the providers are already doing today with your care plans for members? So our member and our family is always in the center. That is the spoke of the wheel. It all stems from them. And that member identifies the challenges that they are facing. And I want to just take a moment to really talk about that and talk about what that means, especially in context with what we are dealing with right now, which are children with complex healthcare needs. But above all else, they are children. So when they're setting their goals for their care plan, those goals look a lot different than the adult clinical goals that you might think of. A lot of times when we're engaging with these children, their goals are, I want to join a sports team. I want to make more friends. I want to get an A in these classes. I want to be able to go to prom. I want something social and that engagement. I want to go to college. And so that's different than the care or the goals that may be in what a more clinical care plan. And it's not to say that when we have those social goals, we don't have clinical interventions that are critical for them to be able to achieve those goals. But the goal that a member is working on can be really different and really look different than what might be in a clinical care plan. Because again, it's all person-centered care planning. So yes, we as clinicians, when the social workers and the nurses are working with these families, they may know that getting a child's asthma is under control is the most important thing, but that does not matter, and that is not the goal that is put in the care plan. If the goal of the child is to go to prom, that is the goal that is put in the care plan. So there are the challenge and then the goals, and we then categorize the goals. Are they social? Are they physical? Is it behavioral? We develop planned strategies and interventions, and that is how we can bring in the clinical when even if the goal is social. If you want to join a sports team, then we've got to manage your asthma. If you want to go to prom or you want to have do the school musical, then we need to address some of those clinical goals. And so what we have found and what evidence has found is that you can get buy-in on the clinical and the medical side from kids and from everybody when it's coupled with a goal set by them and it feels as though we're all pulling in the same direction. We measure progress and we document in the care plan. And then why this is a circle and why this isn't linear is it's iterative. As we're working towards goals, new challenges may arise and we adjust the care plan accordingly. As we are working towards goals, the member may change their mind, or a clinical issue may become more pressing, or a social issue may become more pressing. And so this is cyclical, this is circular, and it is ongoing. And all of that work, all of that process is documented throughout this journey. We, with the health plans, work with what is called an interdisciplinary care team. The care team is first and foremost the member and the family. They are the leader, the driver of the team and the care plan. It is not us at the health plan or the clinicians that set those goals, that drive that journey. It is the member and their family. Then we bring in their support system, whether that be caregivers, extended family, school personnel, and of course, clinicians. So this might be nurses, pharmacists, social workers, therapists, psychologists, educators, PCPs, specialists, teachers, etc. Again, when we talk about care planning, it's really important that we recognize that care planning and utilization management are totally separate parts of the health plan. They work with the members on the care plan side, and then the utilization management team goes through prior authorization. When there are changes in that first 180 days to a care plan, there may need to be prior authorization. If there's addition, so remember, the continuity of care period covers your existing care plan. But with these children, as we know and we expect, there may be changes. And so when something changes, then the standard prior auth policies are in effect. We do recommend, if a prior authorization is ever required, go ahead and use the portal, submit electronically where you can. Even if a health plan is utilizing a contracted entity for care coordination, the MCO is still responsible for reviewing those prior authorization requests. We at IMHIP have tried to be helpful on prior authorization, and we've actually pulled together a page where each health plan's link to their prior authorization manual is on one page on our website for you, and you can find that right there. So that could be helpful for special needs children or children with complex healthcare needs, but really for any of the Medicaid members you're serving, because that prior authorization link is for all populations, not just this population. So we want to really reiterate that transition and continuity of care and what that means. So first and foremost, members have 90 days after they've enrolled into a health plan to select a different health plan. Then they have a 180-day continuity of care period. Both DCFS youth, current youth, and former youth, and special needs children. All current health plans, providers, treatments will be approved regardless of network status. If you want to be covered by that 180-day continuity of care provision, you have to be a provider registered in Impact. And then again, we still encourage you to call and notify the health plan just to ensure that this is all implemented seamlessly, just to ensure that we're communicating quickly and from the start on the needs of these children. How will you know which health plan a child is enrolled in? We actually took a screenshot of Medi for you. This is a child who is in a health plan. This is a child in next level, or this is a member. And you will see down here, plan code 59, and that's for next level health. It will say right there, and I'll give you a phone number and whatnot as well, and the effective date. So that is what you're going to be looking for if you're on Medi. How do you enroll? If you are advocating for a member, or you're a member, or you're a family, remember the health plans do not touch enrollment. They do not do that. That is all a state function, and in Illinois, that is contracted out to a client enrollment broker. You can call the client enrollment broker. Their phone number is right there, or you can go to their website. Their website's right there. Here's a little screenshot on the side about sort of what you can see at the client enrollment broker's website. They'll allow you to compare the health plans. They'll tell you what they include. You'll be able to look at the networks. So again, that's going to be the most helpful when selecting a health plan and sort of reviewing that. So that's all that is all at the client enrollment broker's website. So this is not a billing webinar. We do have those coming up, but while we had you, we did want to touch on that because we do recognize it's a really important topic. IMHIP has a comprehensive billing guide. You can see it here on our website. Click that link. It is over 200 pages to give you a sense of the size and scope of it. It covers general billing, claim submission, claim disposition, and then information for all types of providers. It may differ from traditional commercial billing. We fully recognize that. And it might not follow MMAI because, again, that's going to be that's going to follow Medicare rules. So this is just for Health Choice. But it is what we use for Health Choice Illinois, and all health plans use this comprehensive billing guide. I highly recommend it. I am not a professional biller, but it is very accessible. So if you are looking for a tool for your office managers or for people within your office, or your billers, I highly recommend it, especially if you're hiring new people. Very helpful, very accessible. And we update it, and when we update it, we flag what we have updated so that it maintains, it's still very usable. We were asked to discuss sort of member appeals process and what does that look like. Members have appeal rights. They are in the member handbook. Appeals that are upheld by the MCO can be referred by the member to the next level, which is the HFS State Fair hearing. In Illinois, a doctor or a clinician can always appeal on behalf of the member. They just have to have written documentation saying that they are appealing on behalf of the member, and that they have the right to do so. But there are always appeal rights. Those are regularly monitored and overseen by the plan or by the state. For provider disputes, there's also a separate process, so you can go through the member appeal right, or you can go through provider disputes. You have the right to file a complaint or dispute with an MCO. It is important to note these are regulated processes that are overseen and monitored by HFS. Even if there's a delegated model, you can always reach out to the MCO. You can always go the provider dispute process. If you want information on each plan's provider dispute process, that is within the IMHIP billing guide. What we have found is we've worked with providers through these processes over the past year or more, is that providers want to avoid the traditional provider dispute process. They feel like maybe they're escalating something, and so they go through unofficial channels. What I can really say is we highly encourage you to use the official channels. Use the documented provider dispute process. Because of that, it's all monitored. We have it documented. It is overseen in a way that is really very regimented, and so that is what we are recommending. Well, we did not specifically dive into the specifics of billing. We do have sessions coming up, and that is we just completed one on ORP. We're doing one on rosters next month, and then we're going to start diving into our general billing topics and specific billing topics throughout the rest of the year. For special needs children, because we know that you guys are going to want to be working with them regularly for these populations, we've created a specific escalation guide for these children, where it's your initial point of contact, your initial escalation, and your secondary escalation should you arise or should you have an issue with any of these children. For care coordination or billing purposes, that is on our website. You can use that there. That also highlights that we have a lot of key contacts on our website. You can use these throughout the process. We update it regularly. If you do notice that we have a mistake, go ahead and report a change here on the side of our website, and that lets us know, one of the contacts we have for one of these areas is out of date, and we need to update that, and we go ahead and do that for you. Also, just so you know, we don't email out or have a printed directory. It's all on our website. In the past, we would email out directories for people, or we would print them out, but it's not feasible. We found people would have the older versions of it. It wasn't helpful, so it's all always just on our website. To make it more easy for you, again, we do have that prior authorization link, that tool that has information for all of our health plans. That is at that link. We have updated that. We do make sure those URLs are still working. Should you ever be using our website and a URL is broken, just let us know. There's a contact us link on our website. Let us know and we'll go fix that for you. Other things that are on our website that might be helpful for this transition or anything that while you're interacting with Medicaid managed care organizations, in addition to the prior auth links, we have links for all the provider manuals. We have those key contacts guide. We have those billing guides. We have roster information. We have FAQs. We regularly update those URL changes. But of course, if you notice one we missed, just let us know. And finally, if there are tools or resources that you would like, let us know. Give us suggestions. We're here to help you. And we all at IMHIP and the Medicaid health plans and you with the providers, we're all focused on the Medicaid member. That is our mission. That is our journey. That's what we're all here to do, and we want to do that together. So if you have ideas on how we can do that better, don't hesitate to share. Here's our contact information. We'll be sending this webinar, this PowerPoint out to you, but you will have this information, but additionally, you are always able to contact us through our website. Should you lose this slide or lose this PowerPoint, there's a quick little contact us button on our website, so do feel free to go ahead and contact us that way.
My name's Elena Kennedy. I'm the Chief Operating Officer, and on behalf of IMHIP, we'd like to say thank you so much for attending today's webinar. To learn more about our association, upcoming events, and webinars, please visit our webpage at imhip.net. We look forward to working with you soon. Have a good day.